How often do you think about death? I would say I think about it probably more than most, partially because of my job. A study by the Statista Research Department in the UK found that 11% of people think about death every day, and 5% of people never think of death at all. I think realistically, the average is somewhere in the middle. And I'm hoping that by being at this talk today, I can convince you to think a little bit about death and what you want the end of your life and beyond to look like. And then hopefully you can also share what you want with your loved ones. My name's Caryn. I've been a nurse for about 6 years, and I started medical school in 2023. And I think I'm hoping to provide some insight today into death and dying that you might find helpful. Before I get started, there's a few things I want to mention. Death and dying can be really hard to talk about. And I think it can be even harder when the person facing death and dying is young. I'm hoping to use a little bit of humor to tackle some of the topics today, but that's not to take away from the fact that grief and loss are devastating to deal with. And I also want to point out that part of my perspective includes good versus bad grief, or death rather. And I don't want to take away from the fact that death and loss are, like I said, devastating to deal with, but rather that I think there's a lot we can do to make dying better for people. So when I talk about, good death, I just think that there's a lot we can do to make dying and death less difficult. And I think in my mind, the reason that I'm doing this talk today can be summarized in a quote by Ben Franklin, a slightly problematic individual. Nothing can be said to be certain except for death and taxes. So in both my personal and professional life, I've experienced a lot of loss. Through the pandemic, many people died. Many of my patients died. And often, because of the restrictions that we were all familiar with, they wouldn't have anyone with them. If they were passing away in the hospital, they would be alone. And I would often go, if I was able to, and sit with them, hold their hand, and just tell them that they weren't alone and that I was with them. And on more than one occasion, some of my coworkers found me in my patients' rooms, talking to myself, seemingly, from the outside looking in, which I'm sure was very, very strange. But what some of them didn't know is that when I was about 15, my aunt passed away in one of the ICUs that I worked in. And I wish I hadn't had that experience, and I wish I still had my aunt, but I think it definitely helped me have a lot more compassion for the patients that I care for. I'm going to lean on a few anecdotes from when I worked as a nurse. The first was when I was working on a ward at a hospital. I had a patient who had an infection and they needed antibiotics. Very common story in the hospital. And they needed IV antibiotics. So when I went to give them their medication, I realized that their IV was no longer working. So an IV is just an intravenous line. And essentially, I had explained to the patient, I'm going to need to give you a new IV, so poke you with a needle and give you your medication. When I explained all this to the patient just sort of said, oh, do I have to? And I said, well, no, we don't have to do anything you don't want to do. But if I don't give you your medication, your infection will get worse. So I explained that to them and said, if you are okay with that, I'm happy to get the doctor and they can come in and speak with you about, what you want moving forward. And they just looked really, really relieved. So a few minutes later, I found the physician that was looking after this patient, and they went in to speak to the patient. And when they came out, they said the patients decided to pursue MAID, or medical assistance in dying. And for those of you who aren't familiar, MAID is legal in Canada. And essentially what happens is the patient requests it and gets assessed by two different healthcare providers, a doctor or nurse practitioner, for both their understanding of the procedure and their ability to consent to the procedure. And during the provision of MAID, a cocktail of medications is given to the patient that sedates them and then causes cardiac arrest and death within minutes. And for a patient who is maybe at the end of their life, I think for some people, choosing MAID is a bit counterintuitive. Generally, at the end of life, people value time. People want more time. And that's not always something that we can give them. But often, I think dying can take longer than people are expecting, and also it can be filled with a lot more suffering than people are prepared for. And I think that in choosing MAID, my patient recognized that time was no longer the thing that they valued the most. They wanted quality time with their family, not necessarily more quantity. And I think that in order for them to make that decision, they really needed to know what it was that they valued the most. There was a time in the ICU when I was looking after a patient who had been there for about a week. They were walking the line of, won't I get better? And unfortunately, they took a turn for the worse, and there was no longer any chance that they would recover from their illness. So the patient's spouse and a family friend came into the ICU and spoke with myself and the physician looking after the patient. And collectively, there was a decision made to transition from attempting curative treatment to palliative care. Now, palliative care is something that has a lot of misconceptions about it, but essentially palliative care means that we're focusing on giving the patient the greatest quality of life within the context of their current illness. Now, if you're unwell, sick, let's say have end-stage cancer and you're living at home, that can mean a lot of pain medication and spending some time with your family. If you're in the ICU, as I'm sure some of you know, a lot of our patients require a lot of support to stay alive. So that can mean things like blood pressure medications, breathing tubes, other medical devices that people generally get squeamish talking about. And so on the day that we were transitioning the patient to palliative care, the spouse and family friend came in, and the spouse told me, I think we're going to say our goodbyes and leave. I said that was okay. I would just try and stay with the patient, make sure that they're comfortable. And the patient's family friend actually turned to the spouse and said, I think you should try and stay. I think you'll regret it if you leave. And at that point, the patient's spouse told me, I've never seen anyone die and I've never seen a dead body before. And I can't imagine the first time going through something so big being when the love of your life is passing away. Seems like a really unfair situation. So I explained a little bit about what to expect. And we always try and prepare families for what to expect when a patient is maybe imminently experiencing death. And one of those things is agonal breathing. So when someone is approaching death, they can look like they're trying to drink the air or make sort of like a snoring noise. And it's just a bit disconcerting if you're not prepared for that. So I explained, it's a brain reflex. The patient's not aware of it. It's not bothersome to them. And generally it passes very quickly. I explained a little bit about what we were going to do, including administering sedatives and pain medication. And the spouse considered it for a couple moments and then said, okay, we'll stay. So we all sat down and the patient's family friend started telling a funny story about the patient. So we were all sitting there kind of chuckling at this story they were telling. And then the patient's spouse took over and told another funny story about the patient. And while we were all sitting there laughing at this story, the patient passed away. And a few moments later, the spouse took the patient's hand, was just kind of watching them, and I was sitting behind them, just trying to be quiet and supportive. And then the patient's spouse turns to me and says, "That was nothing like the show ER." And it's like, that's good. I was quite relieved because that's not always how patients get to face death in the ICU or anywhere. But they did tell me that it was not what they expected, and that they were grateful that it was calm. And they were also grateful that they had stayed. And I think another thing that we need to generally talk more about is our expectations around death. And the last anecdote I'll share is also from my time in the ICU. There was a patient I was looking after. Of course, it was a holiday, Christmas Eve, and they were bleeding. So we tried to manage them in the intensive care unit, and they just got sicker and sicker. And eventually the team decided we needed to take the patient from the ICU to the operating room so that we could get a surgeon to try and stop the bleeding. And while we were on our way from the ICU to the OR, the patient had a cardiac arrest, so their heart stopped. And generally, when you're in the ICU, if your heart stops, we do CPR, or cardiopulmonary resuscitation. Another word for it is compressions. And I've worked as an instructor for the Heart and Stroke Foundation, and I've been on the co-team at the hospital, so I've done a lot of CPR in my day. And whenever I'm teaching people how to do it, I always tell them that if you're breaking ribs, you're doing it right. And I think CPR is really important to talk about because if you end up in the hospital, that is generally something that will be offered to you or your loved ones. And you might think that breaking ribs is difficult. But if you think about the fact that you're, nervous, you've just seen someone perhaps die, and I'm at work in the ICU or I'm on a ski hill in an emergency, I have a lot of adrenaline. And hopefully the cameras are being kind to me, but I'm 6 feet tall and I'm 180 pounds. So I have a little bit of an advantage over my more petite colleagues. So generating that amount of force is not difficult. And whenever I try to explain sort of what to expect when people are doing CPR, I always tell them that if you've walked down a trail on a cold autumn morning and you've snapped a twig under your boot, that's kind of what it feels like. And if you think about how much force is required to break ribs, how much a broken rib hurts and how long it takes to heal, that should give you an idea of whether or not you or your loved one want CPR. Now, if you're young and healthy, 20 years from now, broken ribs healing will be nothing but a blip on the radar. But if you are unwell, if you're elderly, if you're maybe trying to prioritize quality over quantity for your loved one, CPR is maybe something you want to think twice about. Now, I've talked a lot about what dying can maybe look like. And I think another important thing to talk about is what happens after death, because I think there's some things that you and your loved ones might want to know. In some cultures, obviously, like beliefs and values vary a lot, but some people believe that you need to be buried in a certain way and within a certain length of time in order to ensure safe passage to the afterlife. That could mean a funeral. That could mean a celebration of life. That could mean being an organ donor. That could mean not donating your organs. That could mean, burial or cremation. And I can tell you from firsthand experience that not knowing the answers to those questions is agonizing. I had mentioned that my aunt passed away in one of the ICUs that I used to work in, and my uncle, her husband, did not know the answers to a lot of those questions. And seeing him try to navigate making some of those choices, all while dealing with losing the love of his life and also helping his family navigate that loss, was, like I said, agonizing. And dying unexpectedly can happen to anyone. When I was preparing for this talk, my dad dropped dead on December 30th. I was and still am devastated, as is my mother, who's here with me today. And we were on vacation. He was skiing, and he was just talking about how he wanted a cinnamon bun from his favorite coffee shop, and then he was just gone. He had a long course of CPR, and when we got to the hospital, they did manage to restart his heart at the mountain we were on. And when we got to the hospital, they informed us that he was unfortunately brain dead, likely from a massive stroke. And I had a bit of an inside scoop, having worked in the ICU. When you have a loved one who is very sick or potentially brain dead, there's a lot of decisions that you need to make. And one of those decisions is whether or not you want your loved one to be an organ donor, or if they wanted to be an organ donor. Now, in BC, you can register to be an organ donor, or you can donate as a non-registered donor, as long as you have a loved one who can answer all of the questions that BC Transplant wants to ask about you. And if you've ever donated blood, you have a bit of a sneak peek into the politely intrusive questions that they will ask you, specifically about drugs and sex. And I think I was really grateful that my dad was so pragmatic. He also worked in healthcare, and we knew that he wanted to be an organ donor. And we knew that he didn't want a funeral for a variety of reasons. And in my mind, events at the end of life are as much to honor the wishes of the person who's passed as they are to help the living find closure. And I'm really grateful for everything that was done to help my dad. And I think I knew, like I said, I knew about a lot of the little decisions that we would need to make, but I didn't know how much everything would mean to me, how much all of the little things would mean to me. The ICU team was fantastic. The doctor was really, really helpful, and they worked my dad up as quickly as possible for organ donation. And the team from BC Transplant was really amazing. They called us multiple times to explain the process, including when they were on their way to Vancouver with my dad's liver and kidneys for 3 organ recipients. And I'm so grateful that even though he can't be here today, he was able to give 3 people a new lease on life. And after everything had happened, when I spoke to a therapist, they used a term I hadn't heard before called clean grief. And I think that having spoken to my dad about some of these things before he passed just allowed me to know that I was doing the right thing rather than guess. So if there's anything that you take away from this talk today, just please think about what it is that you want and tell those that you love, because they may be here when you're not. And I think that talking about those things will give them the opportunity for clean grief as well. Thank you.